Welcome everybody to the Facebook Live. My name is Beth Faiman and I'm just going to be waiting for people to join. Thank you so much for coming today. I'd love to see you pop up in the chat and I'd love to see where everybody's coming from. Welcome, welcome, welcome everybody as you coming in. Thank you. I'm watching myself from my phone so I can see if I'm talking to myself or other people. And unfortunately, I see other people. I hear, thanks Beth, hi. I am not alone. This is great news. I am my own IT person tonight. So if things go wrong, it's my fault and I hope that does not happen. I'm really looking forward to a great discussion with all of you, and I'm just going to go ahead and give us about another minute or so for those to join. Everybody's popping in. Hi Angela, Jasmine, this is great. Maybe type in the comments where you're coming from. I see some from Florida. Great. I'm in Cleveland, Ohio, and it felt like Florida today. It was 70 and sunny. Oh, I see Robin is coming from CT, Connecticut. That's great. Wow, there's so many great people. Kathy is coming in from, we got North Carolina, New Zealand. I love New Zealand. I was there visiting my friends in Australia, Melbourne and Sydney. I was there about 4 years ago. So I'd love to come back and I'd love to meet you if I'm in there. Got, Canton, New York, South Jersey. We really have a great, great distribution of people here. Oh, good. Wow, Texas. And we have a hi. from somebody that is it Kurt and Susie. Ooh, Stephanie Smith from Toronto, Canada. Most of you who know me, my husband's from Winnipeg, Manitoba in Canada, and I kind of feel like I'm an honorary Canadian. Canada is just a couple hours straight drive up north, about 3 hours, and so I love to go to Canada. My son just took up ice hockey as well, and so he considers himself a Canadian hockey player, so fun stuff. I think we're about 2 minutes in. We have Denise from Chicago, my friend Steve. Hi, Steve. Also from Florida, but he knows and I know who he is, and so he doesn't have to put his location. All right. All right. Well, okay. My name is Beth Faiman. I want to thank you all for joining in today. Gosh, this is great to see all of you from all over. I think I was instructed to give maybe 1 more minute for everybody to get set up in here, and I'll do my opening remarks and we'll get into some question and answers. Fortunately, many of you had sent in some questions ahead of time, but what I'd like to do is try to get to maybe 1 or 2 of the prior questions, and then I will get to the ones in the chat. These half hours, I was just saying, go so quickly, and I really enjoy being able to do them and answer as many questions as I can, so I'll try to be brief and to the point. And remember, you can always go to myeloma.org, has lots and lots of resources for you so that you can be able to research on your own. We also have the cancer answer line, so anything that I don't answer for you today, you can also go to the cancer answer line as well. Okay, we are, I think we're good. Oh, by the way, Steve is a goalie. That's great to hear. Wonder how your knees are these days. Okay, so hi everyone, I'm Beth Faiman, and I'm thrilled to welcome you to this special Facebook Live event as part of the Myeloma Action Month. Myeloma Action Month is a global social awareness campaign that takes place every March to raise awareness for multiple myeloma. Every March, we urge you to champion Myeloma Action Month to make impact on those living with myeloma. Throughout March, we're shedding light on multiple myeloma and empowering patients and care partners with valuable information. Whether you're a patient or a care partner or simply curious about multiple myeloma, this question and answer session is for you. Drop your questions in the chat and I'll do my best to address them during our live discussion. And if you're looking for more ways to get involved during Myeloma Action Month, please be sure to visit www.myelomaactionmonth.org. And don't forget that there is going to be a broadcast with Dr. Saad Usmani from Memorial Sloan Kettering, and of course Dr. Joe, and everybody knows Dr. Joe as well. So let's get started. Okay, let's see who's in. Let's see if there's any questions in there yet. I'm going to get started on one of my questions that Linda sent in already. Linda says, my husband has multiple myeloma. He has little appetite, but he is forcing himself to eat. Plus he has high calorie boosts daily. Do you have any recommendations for anything that might stimulate his appetite? Dronabinol was prescribed and did not help him. Are there any CBD oils or other things that might help? Linda, I'm so sorry to hear about your husband and his struggles with eating. There are so many things to consider. Number one, what's the type of treatment that he's taking? Is there an opportunity to discuss this side effect? Are you, with the main treating team? And sometimes we have palliative or other specialists that might be managing this loss of appetite, but the treating oncologist doesn't understand the gravity of the situation. I think it's important to not overly stress out about food. Food should be good, and I think sometimes the care partners and patients have different perceptions about the food. So I look at things like their weight. Are they keeping their weight? Maybe they're not eating as much. They're taking their shakes, but their weight's about stable. I look at the treatment regimen. Is their myeloma in a point of remission where they can take breaks? For example, there's a medication called talquetamab, which is a newer bispecific antibody. It has a special target called GPRC5D. And we recently learned at our ASH meeting in 2023 December that if patients had a really good response to that talquetamab bispecific, then you can go to less often, and so the taste is better and the appetite can get better for some people. Another medication called selinexor, which is a pill, and the selinexor is very effective at controlling myeloma for many patients in combination with other drugs. Sometimes by holding or reducing the dose of selinexor, that can help the appetite. So again, I'm not sure, and I don't want to take too much time left on this question, but I'm not sure about what medication he's taking to treat his myeloma. I would like to investigate other causes, get a nutritional consult, and also enact the help of gastroenterologists, and definitely talk with your treating oncology team about that side effect. Take advantage of small meals, take advantage of when you actually crave food, and try to avoid the foods you love so that when you do feel like eating more in the future, then hopefully you'll be able to do that. So thank you so much for asking. I'm going to go back to some of the questions. So, okay, so my wife is 45 years old with no symptoms except for hypothyroid and taking hormone therapy. While comparing her medical records for the last 10 years, they've discovered that the total proteins were always on the high side and didn't cross too high. Is this something to be worried about? Now, without getting into too much detail, because we don't want to do too many details, we want to speak in general about health. Whenever anybody has elevated total proteins, one of the most effective tests we can do is something called a serum protein electrophoresis, or SPEP. That's a test that a primary care provider or a GP, depending on where you live globally, can order in many areas. It looks at the protein. So now sometimes you can have elevated total protein, but there's a lot of different immune conditions that can cause that. So it doesn't necessarily mean it's multiple myeloma. So if she hasn't been diagnosed with multiple myeloma yet, we can see if there's somebody in her community or in her area that can check this SPEP test. And it looks at all the proteins down a gel field for this spike that you can see for myeloma. So again, I would get more information from the GP and look at other things. We have this thing called CRAB criteria. It looks for hypercalcemia, renal or kidney problems, anemia, and bone damage. So putting the pieces of the puzzle together with all the lab tests that look at organ function, blood counts that look at your hemoglobin, hematocrit, and other blood cell indices, as well as that protein test, will tell you if there's something to be concerned about. So I think you need a little bit more information before you start worrying. It's easy to worry about a condition until you're diagnosed, but definitely get more information in the appropriate blood test. And you can always go to myeloma.org. There's an understanding blood test, and it outlines the common tests that we do for myeloma if you're in an area that might not actually have a lot of availability for blood testing. Okay. So going back down in the chat, my question is always the same. Wondering if you reach MRD negativity after induction, what is the benefit of doing stem cell transplant? Well, I'll tell you, if you ask 10 myeloma specialists, Terry, you're going to get 100 different answers, quite frankly. So MRD is a diagnostic technique. It stands for minimal residual disease. That is using a test called next generation sequencing, or NGS, that looks for 1 in a million plasma cells in the bone marrow. Most of you who know me know I've been managing myeloma for almost I don't want to age myself too much. I started taking care of patients in 1994 with multiple myeloma, and more actively more recently in 95, 96. And at any rate, MRD is a technique where we can very specifically see 1 in a million plasma cells in the bone marrow under this next generation. So it's kind of like looking from outer space. We can look at cytogenetics in the bone marrow, so it gives us a good blueprint. But when you do next generation sequencing, it's literally looking like in the back of the eyeballs. That's how close you can look at these things. So anyhow, if you have very little plasma cells in your bone marrow, the idea is that it will translate to an improved progression-free survival, longer remission period. But the jury is still out. In my opinion, I don't use MRD testing to decide whether or not to give people treatment A, B, or C, but if you're losing MRD, I might deepen the treatment. So I wouldn't take away treatment, but I would add on treatment if you're not deep enough. Again, the problem is that I've been in the myeloma space in the 1990s and 2000s. We never achieved MRD. It was like that black swan initiative that Dr. Dury talks about. You never thought there was a black swan until you saw one. Just like we never thought there's a possibility for a cure until we found some potential cure. So I know I keep talking, but I'm very passionate about this MRD. It's a great test, but it's a nice to know, not need to know. I look at the individual picture. So why would you or would you not want to transplant? Talk about the risks, benefits, and alternatives to your providers. I absolutely have many patients that do not go for upfront transplant, and I don't think that's an unpopular opinion with all the new drugs. So if you are MRD negative, or if you had a wonderful response and you say it's not right for me right now, then that's okay. We keep giving you reduced doses of what achieved that remission status, keep monitoring your treatment remission status, and keep a close eye on you. So I don't know if I answered your question, but if you ask, like I said, 10 different myeloma doctors, you'll get 100 opinions. People say, absolutely, still do a transplant if you're MRD negative. And I don't think you need to. I think it's a decision, a personal decision you should make with your treating team. So, okay. What levels of paraproteins and lambda and kappa will you know if you're in the early stage or late stages? There's a lot of confusion with CRAB and such. So, so kappa and lambda tests are different parameters. So when you look at how we diagnose myeloma, it starts with the immunoglobulin. So in our bone marrow, our plasma cells make all the healthy immune cells, or many mature part of the immune cell makes intact immunoglobulins that are Y-shaped antibodies, and the role of the immunoglobulins are to make proteins to protect you from getting sick. They make mostly these heavy chains, IgG, IgA, and IgM, and then there's this light chain component that's kappa or lambda. Now some people will just have the kappa and lambda fly off that light chain structure, so you might not have an M spike or an intact IgG kappa or IgA lambda. So for some people, that light chain is how we measure their disease. And before 2004, before we had a test called a light chain assay, those patients were called non-secretory patients. They didn't secrete the protein. We couldn't measure their disease. Since 2004, we've been able to understand that the kappa and the lambda light chains are a marker of remission status. So the International Myeloma Working Group does have response criteria. So when we start treatment in somebody with a light chain type, let's say your lambda light chain is 2000 when we start treating your myeloma, we still want to see that go close to normal or in the normal range if possible. And then we watch that lambda at the very low level and make sure it doesn't go up by 0.5%, 0.25%. There's different parameters that would be a sign of relapse. So again, what type of protein do you have? How high was it? Where was it located? And then watching that on a regular basis. Now, each provider has different ways of monitoring myeloma. In general, for the first year, I do a monitoring about every month, sometimes more often, but usually every month is all that's recommended by the guidelines. And then once you've achieved this nice remission, we could maybe go to every 2 months or every 3 months if you have a sustained nice remission. So again, the myeloma.org website has a nice understanding labs module. So maybe that would help make it more sense for how to look at the labs. Okay. So Kathy says, I have been on Darzalex since January 2019. How long will it keep on working? Yay, Kathy. I am so happy to hear that you've been on Darzalex for so long. Darzalex is a medication called an anti-CD38 monoclonal antibody. When it was approved in 2015 for patients that had had 4 or more prior lines of therapy, we gave it in the IV and it took all day to give. Now, most people can get a shot in the belly over 3 to 5 minutes. Of course, it takes longer to mix the medication than it does to give the medication, but we can give it on a weekly for 8 weeks, then every other week, and then monthly. Recent studies published at American Society of Hematology meeting in the last years, including 2023, show that newly diagnosed and relapsed patients with myeloma can have nice, long, durable remissions. What's nice about Darzalex is it has very few side effects. We worry about infections such as pneumonias, low immune counts, so watch out for pneumonia and respiratory infections on Darzalex. And then we also want to watch for shingles, so you should be on acyclovir. In terms of how long it'll work for you, for some people with quote-unquote good normal genetics of type of myeloma, a normal fish, not high risk, you can stay in remission for months to years just on daratumumab or Darzalex maintenance, especially if it's given in combination. We have studies for smoldering myeloma with that drug. We have studies for patients that have been on remission after stem cell transplant. And I've had people that have been on that medication since 2017 as well. So the fact that you've been on it very long is a very good prognostic marker. But continue to have your blood counts monitored, continue to live well so you can stay healthy for your next treatment. Try to be as active as you can, not necessarily running a marathon, but just being as active as you can. Keep the blood flowing, make your appointments, and sometimes if you take planned trips, we can stretch out that Darzalex treatment as well. But hopefully you'll be one of our what we call exceptional responders that will continue going on and on for many, many years. So I know I didn't give you a number because I don't know you, but in general, since you've done for a long time, you can continue to do well if you stay on course. Okay, let's see. Laura said, if tandem stem cell transplant do not achieve a remission, at what point would CAR T be an option? M-spike is 0.2 1 year post-transplant, currently taking Pomalyst 1 cycle, asking for my husband. Again, not getting into too many details. You know, when we make these recommendations and answer these questions, we don't know the background cytogenetics of the tumor. But there are, as Dr. and I don't mean to talk to him about him because he's not here, but Dr. Dury always would say there's 3 types of patients. Patients that would go into a complete remission, patients that would go into not quite a 0, but go into back this MGUS stage where there's just this low-level monoclonal gammopathy, and then patients that might not respond well at all. And that's kind of how I view myeloma, is that everybody's different. So we take into account the genetics of the tumor, those FISH tests, so you have high-risk characteristics. Was this LDH level high at diagnosis? Were you really sick at diagnosis? Any kidney failure at diagnosis? We also take into account the patient's age and fitness and other comorbid conditions when we kind of guesstimate how things will be looking. Now, when you had 2 transplants and the M spike is 0.2 1 year post-transplant, if you're on a maintenance Pomalyst, then sometimes just staying on that Pomalyst over time can deepen your response. We've seen this with other drugs like Revlimid and some of the drugs like daratumumab, that just staying on treatment longer can eventually deepen that response. So I would stay the course for right now and get regular lab monitoring. Again, the International Myeloma Working Group recommendations are if the M protein jumps by 25% and then 25% more, and then goes above a level of 0.5. So for example, you're 0.2 right now. As long as that number stays below 0.7, we don't have to do anything. It's, they'll do imaging routinely, etc. But I would say if it, I hate for my slang, but I say if it ain't broke, don't try to fix it. I'm from Ohio. And I think that's the case with myeloma. Sometimes these days, I think we do too much, finagling of the treatments. If you're feeling okay and you're active enough, you had 2 transplants, you're on a nice maintenance and things are quiet, just go with the monitoring. To answer your question about when can you access the CAR T or bispecifics, CAR T-cell therapy is approved for 4 prior lines of therapy or more, unless you find a well-designed clinical trial that will provide earlier access from 1 to 3 prior lines of therapy. So if you go to, you can also, the clinicaltrials.gov is the website that I send people to find out about clinical trials in their area. Again, there is the myeloma answer line that will be put in the chat somewhere, and that will also help provide you the cancer, I keep saying cancer answer line, the myeloma helpline will be able to, it's 452-CURE, will be able to answer your questions perhaps about accessing your area. So good luck, and I would be happy with that 0.2 M spike. Sometimes it never goes away, but that doesn't mean you're not in a really nice remission. So stay positive. My dad was diagnosed with monoclonal gammopathy in 1984. He's now 83 and was just told us he has myeloma. His PET scan's clear, but he's not at an age to get bone marrow transplant. He starts treatment next month. He'll be on 3 medications. I'm desperate for hope. His blood on my end shows that he has anemia. I need to know I'm helpful. So what I advise is I said, try to see if dad will allow you to be a part of these visits. So I had a patient in my office the other day, and her family lives in 2 different cities across the country, and she's in my area. And I said, how about we FaceTime them in? You're here for the office appointment. I'm going to share with you important information. Why don't we FaceTime them? And just on these smartphones, you can pull in the different family members, and connecting with that care team will provide you important information. The 3 drugs are probably daratumumab, lenalidomide, and dexamethasone. And these are drugs that were found to be effective in people that could not undergo stem cell transplant, which is fine because it's a big deal and we don't necessarily need to do stem cell transplants in 2024 for everybody, as we talked before when I was answering Terry's question. But the DRD regimen from this Maya study showed that people can go into nice deep remissions with this shot in the belly, pills you take at home, and some low doses of steroids that you can eventually get rid of. It sounds scary, but it's really kind of considered immunotherapy these days, so it's not the traditional chemotherapy. I have had patients on the DRD study, and many of them have been in their 80s and some of them in their 90s. And these medications are generally very well tolerated. We have to find the right dose or the right medication for the right patient. So the center that you mentioned that your dad is at is amazing. And talk with the care team, get dad's permission to be part of the visits if that's something you're interested in. But I know there's a lot of hope, especially because he's had MGUS since 1984. That's amazing. That tells us that he's got probably quote unquote good type of a myeloma and should do well. Even though he's already exceeded a normal lifespan for a man his age, we still hope that he can get some nice long good quality and quantity of life with this 3-drug regimen. And don't go to Dr. Google. try to access the healthcare team. I know so many great people at Moffitt that I'm sure they're very happy to help you. Going on to Nancy. Nancy says, I'm getting ready to have a stem cell transplant and have some questions. If they harvest my own cells, aren't they also harvesting the myeloma cells too and injecting them into me? That's a great question, and I get that quite often. When you think about how cells develop, in the bone marrow you have these stem cells. When they grow up, they can be anything that they want. The stem cells decide to become either what we call myeloid cells on one side of the tree, is how I picture it, like a tree. And that's where you can get people with certain types of leukemia and blood cell disorders. Or on the other side of the tree are your lymphoid cell line. As you escape the bone marrow into the bloodstream, you get your mature B cells, your mature T cells, and the most mature B cells are the plasma cells. The plasma cells, as I mentioned, their job in life is to make proteins called immunoglobulins that protect you from getting sick. So when you're harvesting the stem cells way up here in the bone marrow, you're not going to be getting the myeloma cells collected through there. The apheresis machine will take off just those stem cells, will float to the top of that apheresis machine, and that's what's put into a little baggie and frozen with preservatives so we can give them back to you. Now, many studies from the 1980s on have said, well, maybe myeloma cell has been expressed on the stem cell clone. And so that might be it, but numerous studies have shown the effectiveness of stem cell transplant in deepening remissions in myeloma, and then you go on to a maintenance phase afterwards. So there's different studies that we can offer you, and depending on where you're located geographically, to test different ways of doing maintenance in myeloma with newer drugs that are now available. But the standard of care is a pill called lenalidomide, which is offered to most people, also called Revlimid, and so that will deepen any remission and continue to keep things as quiet as possible. So number one, we don't think that your myeloma will be harvested with your stem cells. It's just your stem cells. And then number two, there's more of an immunologic effect that occurs with that stem cell transplant. And the studies have shown that transplant's a good thing for many different people. And oh my gosh, is it really 7:27? Oh my gosh, these just fly by. I gotta go look at my question and answer and stop talking so much. I could do this for hours. Thank you for bearing with me. What can happen if you're on Zometa and your calcium levels go up to 12? So Zometa, or zoledronic acid, is a medication that's intended to strengthen your bones. It takes calcium from your bloodstream and puts it back into your bones. The important part of Zometa is that we used to give it monthly forever, and then we found out that some patients had problems with their teeth. It didn't need to be given forever. It can be harmful for the kidneys in high doses for long periods of time. If you want to learn more about bone health and myeloma, Dr. Jens Hillengast from Roswell Park and I did a program in November of 2022 on living well with myeloma, so I would suggest to go watch that if you want to learn more about it in the interest of time, because it's almost 7:30. But if your calcium levels go high, we like to say, why is it high? Is it high because of the myelomas acting up? Is it high because you have a secondary parathyroid problem? So getting appropriate blood tests, making sure you're not dehydrated, and making sure that the myeloma is in remission, because sometimes there needs to be a change in the myeloma regimen to effectively control it. So just like anything, like high blood pressure, diabetes, your body gets used to the medications that you're being given. Sometimes you need to change things up with a different class of immune therapy or different class of drugs to get you back into a good remission where you can hopefully stay for a long, long time. And I think I have time for maybe one more question. Okay, so let's see. What's one can I do quickly? I mean, everything looks so wonderful here. And thank you, Robin, for putting things in the chat. Robin Tui, everybody. Yay, Robin. Thank you for being there as a support system. Okay, we'll do one more. Wanda says, about to start second-line treatment, Dara, Revlimid, Dex. How effective is that drug? If you are high risk gain of 1Q, only remain in remission for 13 months after induction, and chose not to have a stem cell transplant, although eligible. Wanda, there's even though you have high risk with a gain of 1Q, we know that there are medications out there that can help. The daratumumab anti-CD38 is a very effective regimen to control myeloma. There's other anti-CD38. There's a medication called isatuximab as well. There have been some studies that show that anti-CD38 can help control patients maybe a little bit better with the gain of 1Q, but I think in general, the Dara-Rev-Dex is a really effective regimen. We talked about that with the gentleman, the older gentleman that had MGA since 1980s is now going to be offered that. It's generally well tolerated, and I think just if you have one high-risk clone, sometimes your body doesn't behave high risk. It's taking the medication, monitoring the disease, and it's okay if you didn't opt in for a stem cell transplant, because sometimes you can change your mind or get in a good clinical trial with a bispecific antibody or CAR T-cell therapy. So many people are concerned about being in a clinical trial, but I think clinical trials are a great way to get access to newer medications. You can get financial help with reimbursement for driving expenses, sometimes overnight hotel expenses. You get your own study nurse, you get advanced practitioners like me, doctors, a whole team of people that are oftentimes willing to help you as well. So, gosh, I'm over the time. This was so much fun. Thank you for listening to me. I think I have to close out now, or I'm going to be getting into trouble from they're going to take over my internet. So I wanted to say thank you now for our sponsors, and I close out the window that had my sponsors. Oh my gosh, all these wonderful people that helped support us for this event. Thank you so much for joining in to this event. I hope you learned something to help. Hopefully you learned something that will help you in your practice or with your friends or family. I'm just scrolling down to say thank you to our people that help support this. Where's our people that help support this? I am the worst IT person in my life. Hold on. Jason sent this to me. Jason, I'm so sorry. I actually was doing pretty well, and then now I screwed it up. Oh, pardon me for my French. Okay, here we go. Myeloma Action Month sponsors, I want to thank you and take a final moment to say Myeloma Action Month sponsors: 2seventy Bio, Amgen, Binding Site, Bristol Myers Squibb, GSK, Karyopharm Therapeutics, Pfizer, Regeneron, and Sanofi. We couldn't do it without you and the generous sponsors. Please join into Dr. Sanu Usmani and Dr. Joe McHale. I'm not picking one or the other. I love them both. I think they're both very knowledgeable, and they're going to be doing the next Myeloma Action Month Facebook Live. If you have any questions, until there's a cure, there's the IMF. Go to myeloma.org and look at all the resources they have there for you. And thank you so much, and have a wonderful day, evening. Bye.